Heart, Part 3. Heart failure is a progressive condition where the heart is unable to pump enough blood to meet the body's demands for blood flow and oxygen delivery. Angiotensin converting enzyme inhibitors and angiotensin receptor antagonists are a treatment, and beta blockers can also be effective. Aldosterone inhibitors are effective additions to these medications. Heart failure with reduced ejection fraction has characteristics that were formerly termed systolic failure. Heart failure with preserved ejection fractions has characteristics that were formerly termed diastolic failure. The causes of left ventricular failure can be grouped as impairments in cardiac contractility, chronic increases of afterload or restrictions in ventricular relaxation and filling, or chronic increases in tissue or blood flow demands beyond the range of normal cardiac output, as seen in hyperthyroidism and some cases of anemia. The effects of decreased cardiac output are fatigue, exercise intolerance, poor capillary refill, cool extremities, peripheral cyanosis, decreased renal perfusion and function, and neurohormonal compensatory mechanisms are activated. The effects of elevated filling pressures of the affected vessels and the atrium are increased pulmonary vascular pressures, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, pulmonary edema with hypoxemia and pulmonary crackles, and right-sided failure. The primary failure of the right ventricle can be caused by chronic lung disease. It is termed cor pulmonale and results from hypoxia-mediated pulmonary vasoconstriction. This commonly develops secondary to left-sided heart failure. Chronic elevations of pulmonary vascular pressures are due to poor contractility of the left ventricle that create increased afterload for the right ventricle. As occurs with left-sided heart failure, increasing right ventricular end diastolic volume to achieve increasingly larger preloads enlarges the ventricle and alleviates filling pressures from the right atrium. Systemic venous pressure rises, promoting peripheral edema that is manifested by the swelling of the feet and the ankles. Venous congestion can also affect the liver and GI structures, manifested by ascites and abdominal discomfort. Imminent when left-sided heart failure is already present. The effects of decreased cardiac output are a decreased blood flow through the lungs, which decreases the filling of the left side of the heart, reducing systemic cardiac output. This often develops secondary to left-sided failure and is associated with elevated pulmonary vascular pressures. The patient will have increased systemic venous pressures, dependent edema, particularly pitting edema affecting the ankles and the feet, hepatomegaly and ascites, GI engorgement, and jugular venous distension. Left ventricular end diastolic and end systolic volumes gradually increase and the chamber dilates with thinning of the ventricular wall. The ratio of stroke volume to end diastolic volume, or the ejection fraction, decreases, giving rise to the term heart failure with reduced ejection fraction. The chest X-ray can detect cardiac enlargement. The echocardiography is a method of assessment of the chamber volume and ejection fraction with expected findings to include an increase in chamber size with wall thinning and an ejection fraction of less than 40%. Fluid retention increases the cardiac preload, which is predicted to increase the cardiac output, but only to a limited amount. The lungs' vast, delicate capillary network is highly susceptible to increases in hydrostatic pressure. Pulmonary congestion can stimulate lung receptors, producing a sensation of dyspnea. Elevated pulmonary vascular pressures will impede the right ventricular output by increasing right ventricular afterload and reducing right ventricular stroke volume and the cardiac output. The gradual decrease of the cardiac output will promote pulmonary edema. The ANP and BMP are peripheral vasodilators. These help the heart by reducing afterload, and these natriuretic hormones promote renal sodium excretion, reducing the total body fluid volume. In heart failure with preserved ejection fraction, the left ventricle is stiffer than normal and it cannot relax completely, thereby limiting the volume of filling during diastole, which reduces the stroke volume. It is caused by the loss of compliance of the ventricular wall, which limits filling. The stroke volume is below normal even if the ejection fraction is normal. Conditions that chronically increase afterload are hypertension and aortic stenosis, and these are both common causes of heart failure with preserved ejection fraction. The reduced cardiac output limits activity and exercise intolerance. It also predisposes the individual to fluid retention and pulmonary congestion. Imaging will show an enlarged heart with a thickened ventricular wall, reduced ventricular volumes, but the ejection fraction is about normal at 50%. This is the vicious cycle seen in this image that actually perpetuates heart failure. A decreased cardiac output and blood pressure are signaled by the baroreceptors. Compensatory mechanisms include increased sympathetic stimulation of the heart rate and contractility, and increased RAS activity and vasopressin secretion. The fluid retention is secondary to aldosterone, and vasopressin contributes to preload, but at the risk of further dilating the heart. Venoconstriction increases preload and contributes to ventricular enlargement. Sympathetic vasoconstriction is increased by angiotensin II and vasopressin that increases the blood pressure but also increases afterload and the work of the heart. The increased ventricular volume and wall distension promote cardiac fibrosis and slippage of fibers, thinning the wall. The fluid retention contributes to elevated pulmonary vascular pressures and dyspnea. The ANP and BNP secretion increases, but it is inadequate to stimulate renal excretion of retained sodium and water. All cardiac valves open and close passively in response to pressure differences between cardiac chambers, and routinely form a tight seal when they are closed. The tricuspid valve is on the right side, and the mitral or bicuspid valve is on the left side of the heart. One-way valves are anchored by fibers to special sections of cardiac muscle called papillary muscles. These muscles contract along with the rest of the ventricle and pull down on the valves to counter the effects of increased ventricular pressure. AV valves open and close according to pressure gradients between the two chambers they connect. When arterial pressure exceeds ventricular pressure, the valve opens, allowing blood to flow from the atrium to the ventricle. When ventricular pressure exceeds atrial pressure, the valve closes, preventing blood flow back into the atria during ventricular contraction. The two ventricles are connected to their outflow paths by semilunar one-way valves. The right ventricle is connected to the pulmonary artery by the pulmonary valve, and the left ventricle is connected to the aorta by the aortic valve. Aortic and pulmonary valves also operate by pressure gradients. The closure of the semilunar valves creates the second heart sound, S2, which signals the end of systole and the beginning of diastole in the cardiac cycle. S2 can sometimes be heard as two sounds due to the separate closures of the aortic and pulmonary valves. Cardiac valve diseases have two hemodynamic phenotypes. One is stenosis, which increases the resistance of the heart valve, requiring higher chamber pressures to maintain flow, and the other is regurgitation, that is backflow due to insufficient closure of the valve. Both of these problems may be present simultaneously, especially in conditions that cause thickening and distortion of the valves, like atherosclerotic plaque development or inflammation due to bacterial endocarditis, rheumatic heart disease, and some autoimmune diseases. The most common valve disorder is aortic stenosis, followed by mitral regurgitation. Three major causes of aortic stenosis are degenerative calcification of a previously normal aortic valve, calcification of a congenitally bicuspid valve, and inflammation resulting from rheumatic fever. Degenerative disease of a normal aortic valve increases with aging and shares some pathological features with atherosclerosis. Impediment to left ventricular outflow is aortic stenosis that results in elevated left ventricular pressure and ventricular hypertrophy. A systolic pressure gradient is present between the left ventricle and aorta, and stroke volume is reduced. The S2 is diminished in intensity, and there is a crescendo-decrescendo systolic murmur that does not extend beyond S2. Arterial pressure and pulse pressure are reduced. There are three major clinical presentations in advanced aortic stenosis. Angina due to the combination of increased myocardial oxygen demand of the hypertrophied ventricle, exertional syncope due to inadequate cardiac output, and heart failure due to impaired cardiac output. Mitral regurgitation can be primary due to a structural defect of one or more of the valve components. It can be secondary if the valve is structurally normal, but the valve opening is widened by left ventricular enlargement. It can also present acutely due to papillary muscle rupture within days of STEMI, or chronically due to valve degeneration or inflammation. In mitral regurgitation, a portion of left ventricular output is forced backward into the left atrium, and thereby forward cardiac output into the aorta is decreased. Hypertrophic cardiomyopathy is characterized by left ventricular hypertrophy that is not caused by chronic pressure overload. In HCM, the systolic contractile function of the left ventricle is increased, but the thickened muscle is stiff, causing impaired ventricular relaxation and high diastolic pressures. Gene mutations can lead to HCM, which is often inherited as an autosomal dominant trait. Most of the mutations involve genes coding for components of the contractile apparatus, which is myosin, actin, troponin, or tropomyosin. The hypertrophied and disarrayed cardiac muscle may trigger ventricular arrhythmias that can cause syncope or sudden death. Thickened left ventricular wall and increased systolic pressure associated with outflow tract obstruction can contribute to increased myocardial oxygen consumption and may precipitate angina. Most common cardiac abnormality found in young athletes who die suddenly is hypertrophic cardiomyopathy. In the cardiovascular development, the oxygenated blood from the placenta travels to the fetus through the umbilical vein. The ductus venosus connects to the inferior vena cava, joining systemic venous blood from the lower part of the body. Mixed blood enters the right atrium, flowing through the foramen ovale to the left atrium, and then to the left ventricle and aorta. Venous blood from the upper body and head enters the right atrium by the superior vena cava. From here, the deoxygenated blood may flow to the left atrium, or it may enter the right ventricle to be pumped out into the pulmonary artery. From the pulmonary artery, most of the blood flows through the ductus arteriosus to the aorta. The aortic flow in the fetus is relatively low in oxygen, particularly the blood flowing to the lower part of the body. Lower abdominal branches of the aorta form the umbilical arteries, taking deoxygenated blood to the placenta for gas exchange. When the infant is born, the lungs will fill with air, the vascular resistance will fall. The umbilical arteries will be pinched off, and the peripheral artery resistance will now increase. The left heart pressures are higher than the right pressures, and the foramen ovale should close. The ductus arteriosus will stop producing prostaglandin E, which will force its closure. Congenital heart defects are the most common birth defect occurring in close to 1% of births annually. Some of these are detected prenatally by ultrasound imaging, and others are not detected until childhood or later in life. Pulse oximetry screening of newborns can indicate the presence of some of the heart defects. Findings that would raise suspicion of a heart defect include cyanosis, tachypnea, decreased pulses, difference in pulses between upper and lower extremities, failure to thrive, hepatomegaly, displaced point of maximal impulse, and cyanosis. Shunting is when the blood makes its way from one side of the heart to the other. Shunting develops when the isolation of the left and right sides of the circulation is incomplete due to either abnormal cardiac structural development or fetal adaptations. With right to left shunting, this allows deoxygenated venous blood to mix with oxygenated blood. This will lower arterial oxygenation and create hypoxemia that will lead to cyanosis. With left to right shunting, this causes the mixture of oxygenated blood with the venous blood. This will not create hypoxia, but it does create volume overloading of the pulmonary circulation that eventually causes pulmonary hypertension that will lead to shunt reversal and hypoxemia. This progression is also known as Eisenmenger syndrome. These are heart defects due to left to right shunting. These are heart defects due to right to left shunting. There are various age-related changes that affect cardiomyocytes, ventricular remodeling, and atrial as well as ventricular chamber size. With age, there is a degradation and stiffening of connective tissue due to depositing of adipose cells and tissue, particularly in the AV groove, and depositing of collagen in the ventricular wall. Age-related degenerative changes affect the aortic valve, mitral valve, and annulus over time. The number of cells in the SA node does decrease with aging up to 90% by age 75. The resting left ventricular systolic function, stroke volume, and cardiac output are preserved with aging, but overall exercise tolerance declines. Although resting systolic function is well preserved, diastolic function decreases with age as left ventricular relaxation begins to slow down. These are specific changes that have been noted with an aging individual.